while I'm thinking about it, talking about reflux, I guess one of the dreaded complications that I have when it comes to reflux of a liquid embolic is the catheter getting stuck, like stuck inside of the patient. Is that a concern? And if it's a concern, how do you avoid it?
Sure. So that's a glue thing. That is one of the reasons why we converted from glue to these DMSO-based agents, because I just personally didn't want to have to think about dilution factors that you have to do in order to tailor how far the glue is going to go in a particular vascular bed, but also having to navigate that risk of the catheter getting stuck, the adhesive quality of glue. That is not an issue when it comes to lava. Lava is cohesive, it's not adhesive. And so in the recently published trial, the multicenter trial that led to the approval of lava, there were no cases at all of a catheter getting stuck in the target vascular bed, and we have not had a catheter getting stuck either. Sometimes what you might feel is some of the vessel spasm, and so you might feel that it could be a little difficult to initially pull. The best analogy I heard was from Dr. Fishman from Mount Sinai, who described it as quicksand sometimes, that you have to just pull back a little tighter, but you can get it out. It just doesn't get stuck. So I want to make sure he gets credit for that because I like it. But ultimately, we have not had any catheter get stuck to the point where we are unable to pull it out. And I guess what I would say is, what I tell people as I'm training, let's say, or just talking about it, is just do these procedures like a normal person. Just, in other words, get in where you're going to go, give the embolic that you need to use, embolize the vessel, and then get out. If you're going to leave the catheter in and have lunch for a half hour, then you might run into problems. But just do what you need to do and get the catheter out, and you're going to be fine.
Okay, fair statement. So after you're embolized with lava, is that catheter still like, let's say you have a pelvic or injury to the liver and you got two spots that you'd like to get super selective on and embolize. Can you embolize one location with liquid embolic and then redirect the microcatheter? Is the microcatheter still in play for a second embolization?
In my opinion, it's not in play. So I think the question that gets asked commonly is, can you clear the lava from the microcatheter using DMSO? In other words, can you essentially flush the catheter?
Right, right.
Well, that's a problem, especially if you think about the small volumes that I said you typically use. If you're in a pelvic branch, let's say, and you want to embolize, you keep in mind that you can always have 0.5 ml of embolic in that microcatheter.
Mhm.
And so flushing out 0.5 ml is actually a lot of liquid to introduce into the system. And there's almost no doubt that you're going to get non-target embolization.
Got
So
it.
then the question comes up, can you just take the catheter out, flush it on the table, and then reuse the microcatheter? And I will tell you, of course, it's possible to do.
Mhm.
But what worries me about that is the assumption that you've gotten out all of the liquid. And I think that may in fact be an assumption that's not always correct. And so what I worry about is that you go back in with that microcatheter, maybe you can use it, maybe you can't. Now you try and put a coil through it, maybe you can get it through, maybe you can't. And I just think it's not worth it. I would not recommend doing that. The only thing I do during procedures is at times you come up to the end of a vial of product, and there's always a decision, do I need to open up another vial because I just need to use a little bit more? And then you remember that you have that 0.5 ml still in the microcatheter. And so what I would do is take some DMSO and clear some of it, but not all of it. So I might take, let's say, zero point 0.2 or 0.3 ml, get that little bit out just to top off what I've done, and then get out. I just don't like the idea of having DMSO sitting behind the cast I've created. I just worry about the stability of the cast in that environment. And so I don't even let it happen. I want the proximal end of the cast to always be the embolic and not DMSO.
In this situation, there's no room or there's no opportunity to do a post embolization angio from your microcatheter. So you do the post. Well, so I guess what I'm getting at is, what's the end point? I guess, like, you know, sometimes when I'm doing coils, I'm like, I'll squirt and I'll say, oh, okay, well, it's not quite occluded. Maybe I'll launch a couple more coils and then I'll retake a picture. So what's the end point with liquid?
I think what you need to do is to have a really good pre-embolization angiogram. So you have a reference picture from a pre-embolization angiogram. You know exactly what the target vessel looks like, maybe the previous order branch that it came from. So you know what that part of the tree looks like, essentially. And when your cast looks exactly like the angiogram did, that's your endpoint. It would be extremely unusual for you to fill a vessel, have reflux, come back, maybe into another vessel that you were totally willing to sacrifice and include in your field, and then do an angiogram and see that there's still flow through that target vessel. All right. That is extremely unusual. And so the way I phrase it is this: you want to inject through your base catheter or your parent catheter. And we all like to get final pictures of what we did. It's good to show the kids, right? And make a little photo album. And so, you take out the microcatheter, you do that final angiogram, you're happy with how it looks, and you're done. Or you're not happy with how it looks, and now you have to go back in with another microcatheter and do a little more work there. I will tell you, first of all, that's unusual. But second of all, it just makes sense to do it that way to avoid those potential risks of non-target embolization. And if it was one of those cases where it took you forever to get the catheter where it needed to
Yeah.
go, we've all been there. It took an hour and a half to get the catheter into that small branch. I think I would argue that's not a liquid case,
Okay.
because you don't want to take that chance that you need to do more and have another hour and a half's worth of work. So if it took forever, I think I would be comfortable just saying, let's just use some small coils and we'll see what it looks like. And at that point, you can always fill in the gaps with some liquids if you want, but probably the coils will be enough, especially if it's a really small distal vessel.